Well, good morning, Wendy, and all. It's a great pleasure to join with you this morning, and I would like to initially start by thanking the team at the Centre for their wonderful help with organising this prospect of making virtual care a reality. My task is really an opening game, that is to look at what the general principles behind designing a digitally enabled, patient-centric and sustainable care model may be. Or as Wendy was saying, taking Geri-Connnect where it started at 1.0 through to 3.0. Obviously, as Wendy would say, I'd like to also acknowledge the country we're living on. That will be different for all of us across Australia as we join in this meeting, but I'd like to pay my respects to elders past, present and emerging. What is the Australian mud map? What does it look like in this space with health and wellbeing, digital health strategies, the explosion of everyone being suddenly interested in virtual care? We need to address, though, the other things that might, apart from the rain across the eastern seaboard, change this map for us. What are the ecosystem tensions that have evolved with COVID and other things? What are the commercial drivers? Are there the funding models that might sustain such a prospect, or are there even the public policy programs that actually might underpin that funding? So we need to look at all those things. What I'd like to do in this brief presentation is to take you through this outline. Firstly, a general look at the health system, the challenges and changing models of care. What's the consumer's perspective? What are our responses as part of the health services delivery systems in Australia in designing and evolving a patient-led infrastructure rather than a patient-centric infrastructure? What have been the, if you like, influences of the COVID-19 factor? And what are the tensions, the subsequent tensions in the ecosystem that have evolved related to that? We've had a predominance of the space by the evolution of EMRs or EHRs, whichever you like to call them. They've been dominating our data capture and sharing, but should they in the current form, or is that really an anachronism of the past that needs to be revisited? And should we have data access that's greater also for the consumer? What's the user experience? What's the future? And I'll end with giving an exemplar related to, as I said, the evolution of the Geri-Connnect outreach virtual service in the Loddon Mallee region of Victoria as an exemplar of what I've been talking about. And finally, we need to consider what our collective challenge is in this whole domain. We all know it's a complex system we work in, a complex silo of points of service, and particularly the still unresolved complexity brought by federal-state divides in healthcare funding. These are things which we have to deal with, unlike some other countries where it's a much more streamlined mix, or at least an amalgam of these funding models and programmatic propositions. As Wendy was saying, if you just take one diabetes as an exemplar of the complexities of someone with diabetes dealing with the health system in Australia, you see all these elements on this slide that they have to potentially interact with. It's a very complex system, and assistance is required, particularly for those who are less capable of organising their own care in amongst a complex system. And this was a slide taken from what Wendy referred to earlier in terms of the Applied Learning Healthcare Systems course, looking at just such evolutions and how we might best design and engage with the consumer in the community. But I'd like to suggest, as I did earlier, that a lot of what's happened in health and its delivery has been biased by hospital service dominance of both the system design and the funding. And this is a slide from George Crooks in Scotland, where he suggests that the balance of care has been largely very focused on treatment, and often in hospital systems in terms of where the major funding goes. And prevention, detection, post-event, that is acute admission event, care, and independent living support have been lesser entities in terms of their relationship to the funding models that have evolved in the last 10 to 20 years. But what should the 2020s be? And according to George and his colleagues, we should be moving to shift that balance of care to look more like this, with a greater focus on prevention and detection of early disease, post-event care, and actually supporting people where they live in the community. This is a shift of balance which is already occurring, especially with COVID and community care, but it's still in evolution and still doesn't have the appropriate underpinning support of funding nor policy. And we've had this come to interrupt our lives in many, many different ways. We've had COVID-19 accelerating sometimes ad hoc development with workarounds with respect to data capture, with monitoring of people's health in their home, and with bringing all that data together at the pointy end. What we really need now is to take those learnings and those opportunities, which the tsunami of COVID energy has provided for us, at least in terms of temporary funding, to take it forward to look at what are the solid enterprise platforms with agile capabilities for well-considered evolution and growth in the terms of the system. In other words, a progressive, evolving system which takes in account of what needs to be reconsidered if the basis for what we've been doing thus far, e.g. with EMRs and EHRs, needs to be reconsidered and reevaluated. But I'd like to draw this particular point. We're talking about virtual care today, but to me, the quote from Josh Emder above, pretty soon there'll come a time when we don't call digital modalities virtual care, it will just be the delivery of healthcare. Really what we're talking about is one component of delivery of health service delivery, and that is it's either face-to-face or done virtually. It's not as though it's a completely separate entity, which sometimes it's become in our recent discussions. It's really digital technology-enabled healthcare, whether it be in person or performed virtually, but the key is it's underpinning models of health and well-being as exemplified there by the Alliance on Health and Wellbeing in terms of their model. But I'd like to also draw this to your attention. What are the personal determinants of health, of people living in the community, not just those who are coming to see us in a hospital area or in a clinic? And if we look at, say, for instance, in the inner circle, that's the determinants of health, we see that there are four predominant types of influences. We've got those things that influence clinical care, and that's about 20%. We have those in the social and economic environment, which have a major determinant of health outcomes and also health of the population. And the physical environment and individual behaviour also contribute considerably. But we tend to make our decisions on the outer circle there on what we observe from personal data that we have shared in a clinical environment. And that's only about 15 to 20% of the data that could be brought to bear with respect to making decisions in clinical care. So in other words, as I say on the right, we lose the richness and the context of the lived lives of these people we're trying to help in terms of the data helping to determine health outcomes as well as diagnostic issues. And we also need to think about what of those are modifiable. What can we do something about? Finally, what are the consumer expectations at home? Is this how someone might say, well, I've got a sore shoulder, doctor, could I just tell you about it? And here's the image of my scapula right now. Or is that unusual? However, what I'd like to say is that people now, for all sorts of other things apart from health, for instance, hotel booking, going to the shopping online, they are presented with things in terms of products and services. That's not how we've traditionally produced healthcare service delivery, but maybe that's how it best be understood and developed so that it can be understood in the same way that those other entities are by people in their everyday lives. So indeed, what do people say? What do consumers say when you say, I'd like to co-manage my care, says the consumer. What are the key issues? Well, this is one set of key issues as evolved in a recent survey done a year or so ago by users in the Scottish health system. Top of the pile, always in those trials, was to tell my story once. In other words, I don't want to tell my story to 6 people in a row just because they haven't handed it forward or haven't got that recorded in a way that transfers it to the next person I engage in a complex system. I'd like to have a meaningful dialogue with the professionals I deal with, not just a summary one in a 3-minute interaction. And I'd also like to have access and understand my data and the guidance that I'm given, and to be able to reflect back on it, have it available to me at any point in time that I wish, not simply on a scrap of paper handed to me as a brief summary note at the end of a consultation. And they'd like to think of things on their own terms, not as we tend to traditionally provide them out of the health service. And finally, the top 5 of their wishes was to unlock or unblock the care I need. In other words, they to have control of what they care to have in their care services delivered to them, and how they have the balance of that care delivered as well. So what we've had of recent times is the very oft-used term of user-centered design. And that very oft-used term of recent times, particularly the last 5 to 10 years, of patient-centered care. I'd like to suggest that what we need to work towards is putting the consumer not in the car, not in the Tesla, but actually in the driver's seat, so that it's actually person predominantly led care in terms of data sharing, control and decision making. And maybe we might eventually get to a third proposition, which is, to use the Tesla analogy, an autonomous vehicle. But that's a bit of a scary prospect that I'll leave to a talk that might be 3 to 5 years from now. On the bottom of this slide, though, we need to take that in the context of the fact that people on the left may have to deal only with carers and family if they're particularly well. But if they're actually engaging in community-based care, it's an ever-evolving suite of people that they're in contact with and needing advice from or resources from. And indeed, it can even get more complex as on the right, where they need to look at that integrated care team, which is involving not to include everyone, but just those who need to be involved in their care. With that sort of simplicity or complexity, depending on the individual, we need to have them not just at the center of their care, but also potentially and hopefully having some control over that care, and also informing their own self-management of their health and well-being, a topic I first started talking about in 1985 when I used to lecture in medical sociology to medical students, but which has got some currency in the last 20, 30 years. So this really is talking about bringing those elements together. If we look on the right, we see that these are all the propositions where people have personal data in all these domains, and increasingly even with devices and wearables, Apple Watches, et cetera, et cetera. But how do we bring all that data together so it might inform, with the consent of the individual, decisions that are made with respect to their health and advice that's given with regard to that? And as George has said on the right, citizens should be curators of their own health data, predominantly, a topic that he's very wont to talk about if you engage with George, and that's been for at least the last 10 years. So if we're going to design a system, an infrastructure that might engage and allow such a proposition that I've talked about in these 2 slides to evolve, what might it look like? And I bring to that proposition a slide from, in fact, George Crooks and his colleague Challoner Shute from Scotland, who run a digital health institute, research institute there. And this is a model that they presented in a webinar for the centre last year, at the end of last year, which I highly recommend to you. This is one slide taken with permission from them. What we have in the centre there is the key issue, which is a personal data store that has health data exchanges that allow people to, with consent, share their data, whatever that may be, personal, health and well-being, social security, housing, economic, whatever that sort of data, with those people they engage with in the community. So not just with the healthcare system here down the bottom, in terms of that sort of record system, but also with the health and care co-management market, the apps that might be out there in the consumer world, independent living devices or supports that might be out there, consumer services, well-being services, no matter what their origin, and then also public health systems. They can do that via different portals that allow that with their consent to occur. But of course, they also, in this sort of infrastructure design, would have the prospect of being able to block any of that sharing, where they might, for instance, not wish the health and care systems to have access to social security data, or conversely, in terms of the individual interaction, say, with an individual physician about a particular health problem. So with that sort of possible infrastructure evolving, because it won't all happen at once, what might be the advantages or the prospects for that? Well, I guess I'd just draw these brief points to your thoughts. The personal integration infrastructure would bridge a citizen's broader life and their health and care service. It'd support person-centred, or even, as I would rather say, person-led where possible, because not everyone might be able to do that, be they cognitively impaired or simply unable or not wishing to do so. That might integrate service to give stronger citizen user control, break down those traditional silos of data capture and storage and the pools that never quite come together of data, respect the complexity of the system for the user as well as sometimes the user's complexity, support innovation, which is critical as we go forward in this ever-evolving world and rapidly evolving world. So there's a choice of many suppliers for both the citizen's point of view as well as health service points of view, but with a rather more focused, coherent route to the integration of both the delivery of that service as well as the availability of data. And just as importantly, offer unfettered innovation centred on citizens that they have a responsibility and a role in helping to evolve, not feeling just subject to. But that requires new efforts. There's more learning needed around how to orchestrate such a proposition. And also it requires acceptance that there may be a variety of suppliers, be they in the commercial space outside the health service, or be those that straddle both in the health service, commercial services, and others that interact together, albeit with the reuse of common integrations. So what might be the challenges then as we try to move from a more person-centered system to a more person-led system? Well, I'd say that this is how technology can help in building that more inclusive experience of care, but we need to go through this progression together, the public, clinicians, and the system, the health system, because we've got to first have people, particularly consumers, see the benefits of that expanded health data exchange. Second, if they do, then we need to give a greater ability for the consumer to hold a personal data pool, which they can consent to share, selectively or not, with healthcare and social service. Not simply to have the current proposition with My Health Record, which is more like a library they can loan a book to from someone, but not actually have a very active engagement with themselves with control. And the next step in that progression potentially is the consumer actually taking control of their data, their interactions, scheduling of any appointments they would like to see, obviously with referral. And that's really for those who wish to, which will be a majority, particularly of younger folk, but increasingly more of older folk who are capable and able and cognitively aware. We really need to look at that progression, because the latter stage there has the great advantage over system-driven interactions, in other words, where the health system tells you what's best for you, where you might, for instance, have health and social care agencies needing to combine, to integrate their care propositions. But it also will underpin the proposition that it attends to privacy and ethical concerns, a terribly important underpinning proposition, along with, obviously, the underpinning cybersecurity necessities that would relate to this. So, how has COVID influenced this? Well, COVID has certainly accelerated the proposition of virtual care, but has it provided for us the best design foundations, as I implied earlier? I guess I'd like to just say one thing about that in this brief presentation. I think we've lost some opportunities with the COVID pandemic, many of them actually, but these two particularly I draw to your attention this morning. The first is, I don't think we've captured the consumer voice sufficiently in how they'd like these services to be developed when they're not in person, but done virtually. More importantly, also, we've lost the opportunity for consumer digital technology engagement and education. For instance, in Malaysia, during the last 4 years, they have taken out to the villages the proposition that everyone will be educated on how to use whatever device they have to connect with their community and their health service, and mostly it's a mobile phone. They're educated on how to organise an appointment, how to capture their data for monitoring at home, how to utilise it for connection with a video conference with any form of health professional or health worker or care worker in the community. That's happened in the community. We're far from that proposition here. It's been very ad hoc. Because we're in a very complex emerging ecosystem where we're talking about 5G and even 6G. We're talking about, and I will in a moment, using the LoRaWAN community radio networks for communication of data, closed and open data. We're looking at consumer data, wearables, smart infrastructure in homes, and the use of IoT and AI behind those scenes. All of these are bringing the communities and technology to a smarter proposition than we had. And indeed, it's that juxtaposition of what happens at home with commercial home products and what happens from a health service delivery connectivity point of view. How does the consumer manage this and maneuver amongst that proposition? When we have major entities like Amazon, Google, Apple, and others joining up how data can be communicated from smart home devices or health service related devices. And in fact, we're drifting therefore towards an interconnected ecosystem where we have commerce, telephony, health, and health promotion needing to find a way to relate to each other in the most effective manner. Indeed, what we need to really consider is how do health and wealth relate in this proposition. And by that I mean, when we devise virtual care systems, are we simply deciding whether we can find a business case that we can sell to our local health service? Or are we actually going beyond that in our business modelling to work out, can we work out a business model or create a virtual care reality system whereby it creates wealth to underpin the actual delivery of our service, thereby not simply being a drain on already utilised resources, or in fact having to steal from other resources to provide the virtual care component of health service delivery. That's an interesting proposition we need to think much more of in this country. So I did mention about my thoughts about EMRs and EHRs with the hospital dominance of how we capture people's health data and their personal data that might relate to health. And John Glaser wrote in the Harvard Business Review, which I'd recommend to you, a piece about a year or two ago, that it's time for a new kind of electronic health record. Well, when we look at the trends across the last 2 years of EHR records, we see all of the ones listed on this slide. And I just draw to your attention the 3 that I've highlighted. I'd like to suggest that, to me, all the others there are very interesting and will have some impact. But improved patient engagement with patient-generated notes and data, that's something I'd like to see. EHRs and data operating across sectors, hospital, community, general practice, home, because the general practice environment and the community environment are the poor cousins in the evolution of the design of these captures of health data. They need not to be, because 80 or 90% of health service delivery and health and well-being decisions are made in the community, not within hospital walls. And yet the EHRs are very largely designed to only provide for hospital service delivery or outreach services in terms of outpatients, but not back into, to communicate back into the general practices or the community service offices out there at the moment. And finally, that instead of having the notes-based EHRs that we have, we need to be working towards more collaborative EHRs that instead treat the chart as a single, dynamically updating and fully collaborative workspace. And in that regard, I'd recommend when you reflect back on this talk, you go to these two papers, because what is really wanting to happen is go back to that consumer who said, I want to tell my story once. So this is a paper on the left that suggests a software design for a fully collaborative, noteless electronic medical record to really revolutionize how we share and record notes in the hospital, in the general practice, also out in the community, or that we share in the bottom slide how patients might contribute to visit notes so that they're immediately integrated into, for instance, that outpatient record in the hospital record, as well as being contributed back to the general practice where the predominant care occurs, potentially in the Australian system. Finally, why don't we have a brief look, because I'm almost finished, at what might happen in the geriatric medicine aged care space, a critical space at the moment, given what we've heard in the recent years from the Aged Care Commission. And what we know from geriatric medicine service delivery, particularly myself and Len Gray on this particular call, and all the other people on this call who are talking or relating back also to community care or aged care in particular, how we might deliver services, at least the virtual care component of those services. So what, for those who haven't heard about Geri-Connnect 1.0, what was it all about to start with? Well, it was way pre-COVID. In 2016, I put a proposition to the Medicare Victoria Fund to fund a Geri-Connnect Vision, a telehealth-enabled shared platform using a basic foundational platform with a common telehealth home monitoring informatics and analytics enabling platform, that it would have two components, an in-care component, because we recognised across the Loddon Mallee region that indeed the greatest need or the greatest lack of geriatrician input was in residential care facilities or in smaller health services and hospitals. And they were getting about 5% of their care plans informed by geriatricians, a very low number indeed. So that was going to be our primary focus. The year after, I also put up, and that was funded to kickstart that proposition, to outreach with telehealth assessments or comprehensive geriatric assessments to those places. And indeed, we started with 5, and now indeed we've got more than 58. It's now 62. This slide needs updating. It needs updating every month or two. Services that we provide to nursing homes in the Loddon Mallee and the Hume region of Victoria, which is about 30% of the landmass of Victoria. The second component, or stage 2.0, was to provide monitoring and home services and support for services at home, as well as utilising the use of those to help with the early diagnosis and identification of early dementia, or support those with care needs in dementia in the community. Unfortunately, in terms of that application in 2018, it was not seen as particularly useful to fund. Interestingly, as we all might be aware, only 2 years later, in 2020, it suddenly became something that we're very keen to fund home monitoring and the provision of care in the home because it was a critical necessity for the COVID pandemic. Well, a missed opportunity, but at least COVID has helped to start this process in terms of some kickstart funding now in the 2020s. So we'd started a plan across the Loddon Mallee virtual care arena to go from 2020 to 22 for this stage 2. But what would Geri-Connnect 3.0 look like? In other words, from 2022 onwards? Well, I'll talk about that this afternoon in another brief talk if you'd like to attend and hear exactly what the more details about Geri-Connnect 1, 2 and 3 and how we've made that both a sustainable and scalable service. But just to give you a quick glimpse in the last few minutes of what we can do into the future and how we've envisioned our development with Kickstart funding. So what might at home look like in that at home component? Well, we've already done a trial with a mobile home monitoring application for community services funded by the Commonwealth, which, and this particular solution just happens to be one of many by a company called NetHealth, actually is integrated into the GP's software. So whatever's being monitored there is immediately in the workflow of the general practitioner, as well as shared via the cloud with the healthcare team that may actually be in the hospital or may actually be in the community. It doesn't matter which. It predominantly started as a service utilised for the monitoring of diabetes and for gestational diabetes in particular, but now is generalised to any chronic disease. It's embedded in the community, it's consumer-led, and it's connected intimately and integrated with the workflows of both hospital EMRs as well as general practice, which is a rare thing in Australia as we speak. We've also done a trial for those who don't have a mobile phone or a smartphone. Well, what do they do to give them equity of access? Well, we've done a trial which is now concluded and reported back to the digital health funding people, looking at IoT being the method by which we capture vital signs and home environment sensing from the home via a small relay box, via the LoRaWAN community radio network, or via a CAT-M1 Telstra IoT linkage, whichever the people find out in the community. And we found in these very far-flung places with people who do not have internet connection that's strong enough to maintain a web connection, or have no mobile phone or no connection that's easy in the far-flung sort of rural and regional domains where we tried to connect people, that we had a 98% connection possibility for connecting data of monitoring for chronic disease or COVID amongst those people. That's one proposition where we have either or both delivering equity of access for people in the community to be monitored. Can we monitor their biomarkers as a clue to diagnostic issues or what their health and well-being is? Well, I recommend you look at another example of one of those sorts of propositions, and I'll talk about this afternoon. There's a company called Drop Biohealth, which does this longitudinal testing on a drop of blood, and that's mailed in, and we can follow a lot of what happens with chronic disease and early diagnostic propositions with that. Also, not having to use any device, there's an Emerald box by the MIT people at Boston, which sits on your wall, and while you sleep, it does a sleep study, which is as good as a polysomnographic in-hospital connected to hundreds of wires study, and also can measure your heart rate, your pulse rate, and whether you're asleep in the bed or not, and whether you're walking around your apartment or not, remotely, without touching anything, without connecting any wires. Interesting prospect, trial, yet to come to a real commercial space near you. And also, have we run out of labour force? Will we have to use, for the early education of how to use home monitoring, virtual care assistants, and then the initial triage of connecting to the health system when people are unwell, so that then people are handed or directed towards a clinician assessment, an in-person or virtual clinician assistant, or into the slight future, using some of how people interact with these propositions, these virtual care assistants or digital brain avatars, to collect early diagnostic data that might inform how their cognitive performance is trailing. And in terms of that, I'm currently developing with a company called Soul Machines just these such propositions to put as a front end to how we interact with people. So finally, to end where Wendy was mentioning earlier, we've been looking at how we actually deliver this healthcare assessment for clinicians. And so looking at a simulation model that might link to virtual care sandboxes or sandboxes where we can bring patient data while we're interacting with the consumer, and there's the clinician, the consumer, and there's online at the point of time collection of their data, whether it be via a NetHealth data or some other firm's data, IoT home sensing, or a bed which monitors how they're sleeping or whether they're actually on the bed or not, or their biomarker results. They can be brought into the consultation at that point in time, or access their health record, or online questionnaires. So take-home messages, the last few sections. Great idea cycles are good, but they need to have a scalable and sustainable business model. So it's all good to have a good model, but you've got to be sustainable. Whose value are we bringing, if you like, value-based healthcare? Is it the older adult whose value it is, or is it the healthcare system, or is it the commercial entities we have to interact with, or the universities? We need to think about what we deliver here, but decide, are we bringing value to the people, the consumers, particularly the older adults whose care we're entertaining? And are we harnessing the power of that captured data, be it personal or otherwise, to drive improved system performance for everyone. How should we come together? Because we need to connect the present while creating the future, and we need to link health and well-being across the community. Thanks very much.